Behcet disease is a chronic multisystem inflammatory disorder. It is characterized by recurrent oral and genital ulcers, uveitis, and skin manifestation and skin lesions. It can also involve the joints, blood vessels, gastrointestinal tract, and central nervous system involvement. How these patients are presenting? Presentation of Behcet syndrome. They can have mucocutaneous lesions like the oral ulcer. In this patient, our case, she was having the oral ulcers, recurrent painful ulcers, known as aphthous ulcers. They can have ulcers in the genital area, scrotal or the vulvar area ulcers, and these ulcers heal with scarring. Then skin manifestation can occur in the form of erythema nodosum, can be papulopustular lesions, or sometimes acneiform nodules. They can have eye involvement or the ocular involvement. They can have eye involvement in the form of anterior uveitis or posterior uveitis. They can have retinal vasculitis. They can have hypopyon. So they can present with redness of the eye, painful eyes. They can have blurring of vision, and they can have photophobia. So eye redness, we have to ask the patient, do you have any eye redness? In our Jervell's mnemonic, E is for eye redness. Is it painful or no? Is there any grittiness or dryness is there or no? Any visual problem like blurring of vision or any photophobia is there or no? So this should be the complete set for our E part of the Jervell's. Arthritis in this patient, in these patients of Behcet syndrome, it will be non-erosive, asymmetrical, and mostly it will be oligoarthritis. So this patient was giving history of two joints involvement. Now she's having the knee joint involvement, but previously she was having ankle joint involvement. Sometimes they can have wrist joint also involvement. So mostly it is oligoarthritis. Vascular component in this patient, they can have superficial or deep vein thrombosis. So our patient was having the deep vein thrombosis. They can also have, some other patient can also have arterial aneurysm or thrombosis. Arterial involvement can also be there. Not only the deep vein thrombosis, arterial thrombosis can also be there. Neurological involvement can be like involving the brain stem or the can present like meningoencephalitis. And these patients can present with venous sinus thrombosis, dural sinus thrombosis. One case, our colleague, Dr. Nadine mentioned in the scenario, one previous scenario coming with dural sinus thrombosis. So we should keep this differential diagnosis over there also. Patient can present with headache, focal neurological deficit with behavioral changes also. GI involvement, they can mimic like inflammatory bowel disease, like our patient was having features like inflammatory bowel disease, but not truly, she was not having inflammatory bowel disease. Okay, they can have ulceration in the gastrointestinal tract. They can present with tummy discomfort or abdominal discomfort. Sometimes they can have abdominal pain and loose motions with sometimes bleeding. In the history, we have to ask the blood is mixed with the stool or it is coming at the end of passing the stool. Okay. Other features like B symptoms will be there. Tiredness. Better we should not say the fatigue on taking the history. It is considered sometimes as a jargon. So better to say tiredness. Tiredness is there, fever is there or no, myalgia, arthralgia is there or no, malaise is there or no. So these are the B symptoms can be present here. Diagnostic criteria for Behcet syndrome. This is clinical diagnosis and it is based on international study group criteria. So what is this international study group criteria? Patient will be having recurrent oral ulcers 3 times to more than 3 times in a year, plus 2 of the following. Okay, the first part is recurrent oral ulcers, 3 times minimum in a year or more than 3 times in a year, plus 2 of the following. Either recurrent genital ulcers or eye lesions like uveitis, retinal vasculitis, or skin lesion like erythema nodosum, papulopustular lesions, or the last one is positive pathology test. It is non-specific test, but it is supportive in making the diagnosis. How to do it? We have to take the needle of 20 gauge cannula and we have to inject the simple needle. We have to inject 5 millimeter deep to the skin, and we will mark with some marker. We can make the circle, and we will ask the patient to come after 24 to 48 hours. If it is positive, patient can develop papulopustular lesion, sometimes papular only, papular bump or pustular also. It should be more than 2 millimeters in size to say the pathology test is positive. So this is about the pathology test. Other investigation, the baseline investigation, we can do inflammatory markers like PSR and CRP. HLA-B20, HLA-B51 is associated with Behcet disease, but again, it is not diagnostic test. Other investigation we should consider according to the involvement of the organs. If the brain involvement is there, we can do the MRI of the brain. If the vascular involvement is there, we can think about CTA or MRA. Other tests like we can do the slit lamp examination if the patient is having uveitis. Colonoscopy, biopsy to rule out inflammatory bowel disease. Management of Behcet syndrome, non-pharmacological management or general management includes patient education and counseling and psychological support, and then we can make the multidisciplinary team. So in this case, we can have the rheumatologist, we can have the ophthalmologist, we can have the neurologist, and the GP should be on board. Management for mucocutaneous involvement and the joint involvement, we can use topical steroid. For oral ulcer, we can use the topical steroid, triamcinolone cream. Colchicine can be used for, as the first line for mucocutaneous and the joint involvement. Immunosuppressive, we can start with the steroid, and we can go for steroid sparing agents like azathioprine, and then the biological agents like tumor necrotic factor inhibitor, infliximab. Ocular involvement, the patient is having anterior uveitis, severe form, we can give systemic steroid prednisolone for acute episode, severe anterior uveitis. Otherwise, eye drops can be used if it is mild or severe. And if it is acute severe episode of eye involvement, we can give the systemic steroid. We can give azathioprine as an steroid sparing agent, and we can think infliximab also here also for severe eye involvement uveitis patient and for refractory cases also. If the patient is having vascular involvement or the neurological involvement, again we have to start with high dose corticosteroid. Better we should start with IV methylprednisolone, then to immunosuppressant like cyclophosphamide or azathioprine. Like our patient is having venous thromboembolism, so anticoagulation can be given, should be given. Anticoagulation should be given. GI involvement in such cases, we can use sulfasalazine or infliximab. We should keep these patients under follow-up. Regular follow-up should be done for disease activity, not only for disease activity, but we have to see the patient for complications. we have to monitor the side effects of immunosuppressive treatment. So this is all about the case of Behçet syndrome. Okay, thank you. Differential diagnosis, yes, can be included like inflammatory bowel disease. SLE can also be included for oral ulcer. SLE can also be included. Herpes simplex infection can be differential. Reactive arthritis we can consider in our differential. But other differential like gout, pseudogout, septic arthritis because of monoarthritis, we can keep these in our differential diagnosis. So thank you very much.
For more detailed explanations and related topics, we invite you to watch our videos on our YouTube channel. Don't forget to like, comment, and subscribe to stay updated with our latest educational content. Thank you.